Welcome to Mayo Clinic Sleep Medicine Podcasts, a series for physicians, advanced practice providers, nurses, and other health practitioners treating sleep disorders or interested in learning about state-of-the-art advances in sleep medicine and sleep health. I'm your host, Dr. Michael Silber.
And I'm your co-host, Dr. Maitri Juna. We are both consultants at the Center for Sleep Medicine at the Mayo Clinic in Rochester, Minnesota.
Thank you all for joining us for today's podcast titled, Does Sleep Apnea Lead to Parkinson's Disease? A recent article that generated much publicity suggested that obstructive sleep apnea was a possible causative factor in Parkinson's disease. Apart from the provocative conclusion, the study really illustrated many of the issues raised by the availability of large computerized population databases and their use in research. To discuss this important study and its possible implications, my guest today is Dr. Michael Silber, professor of neurology and a board-certified neurologist and sleep specialist at Mayo Clinic in Rochester, Minnesota. Mike, thank you for joining us today. Could you start first by telling us a little bit about this new article, perhaps starting with the methodology?
Yes, Maitri, thank you. The article that we're going to discuss today is entitled Obstructive Sleep Apnea, Positive Airway Pressure and Implications of Early Treatment in Parkinson's Disease. The first author is Dr. Lee Nielsen. The team comes from the Portland VA in Oregon. The article was published in JAMA Neurology. It was published first online in late 2025, and I think its official in print publication will be early 2026. So what these authors did was they used the computerized database of the VA system in Portland to identify patients who had been diagnosed with obstructive sleep apnea, and they identified an utterly amazing number. I'd take a deep breath of 1,552,505 patients, and they compared that to over 9 million patients who did not have a diagnosis of obstructive sleep apnea. And then they looked through the records and they waited 6 months after a diagnosis of sleep apnea to see the first mention of Parkinson's disease. And then they looked at how many patients diagnosed with sleep apnea at least 6 months before there's a mention in their records of Parkinson's disease had it, and how many who were not, who did not have sleep apnea had developed Parkinson's disease. So the idea was an incidence study looking at development of Parkinson's disease at least 6 months after sleep apnea was noted or diagnosed and noted in the notes. Now, the first thing they did very well, apart from the enormous numbers, was they pulled out 500 of the patients diagnosed by their computerized algorithm from the records with sleep apnea and looked at the charts to see was it correct. And they found that they had a positive predictive value of 94%. So the algorithm was working very well for identifying obstructive sleep apnea, defined as an AHI or an RDI of greater than 5. Then they did the same with Parkinson's disease, and they had a complex algorithm for diagnosis, computerized, and they pulled out 500 charts, and they found the positive predictive value was 79%, not quite as good, but pretty good for a complex way of trying to identify it. They also matched their controls, those more than 9 million controls, for age, for sex, for race, ethnicity, for smoking history. But as best I could tell, they didn't match it for vascular risk factors. They came in a little later. And then what they did beyond that was they identified those patients who seemed to be on CPAP. And there the numbers dropped. They only identified that 9% of the patients diagnosed with sleep apnea could they find evidence that they were actually using CPAP, which is really disappointingly low in terms of CPAP use in a VA population. But they identified those patients. There were still, even though it was only 9%, there were still huge numbers. And they compared those who were using CPAP to those who did not seem to be using CPAP and looked to see whether there was a difference in the development, in the frequency of those two subgroups that developed Parkinson's disease. So that was the methodology. And I guess those were the main features, though, of course, if you read it, there's a lot more details.
So, what were the results of this study then, Mike?
Yes, well, again, they waited 6 months before they decided somebody had a new diagnosis of Parkinson's disease. And they did indeed find that those with sleep apnea had a higher frequency of Parkinson's disease developing than those who did not have sleep apnea. The hazard ratio was 1.92, implying approximately twice the risk in those who had sleep apnea compared to those who did not. I should just mention in those vast numbers, of course, only 10% were women. I mean, it's a VA population, but even that was large numbers of women. There was a good mix of ethnicities and races. 16% of the subjects in the study were Black. So they then did a number of secondary analyses. The first thing they said was 6 months enough? Do you think some of those patients who perhaps developed Parkinson's, say 7 months after a diagnosis of sleep apnea, actually had Parkinson's before? So they did a sensitivity analysis waiting a year and found the results were actually even more significant. The hazard ratio went up to 2.8. They found that women seemed to have a greater risk than men, odds ratio of 4. I don't know what that means. They then adjusted for BMI in case that had an effect. No, it didn't. There was still more patients in the sleep apnea group who developed Parkinson's. They then looked for a dose effect. And that's important in these studies. They compared those with mild sleep apnea to severe sleep apnea. And first, they pulled out charts and checked that the algorithm was correctly identifying mild versus severe. It was 99% positive predictive value. And, we like to see a dose effect if this is significant. In other words, those with severe sleep apnea should have more Parkinson's than those with mild if this is a causative factor. In fact, the odds ratios were pretty much the same. But those who had mild sleep apnea, they only started significantly developing more Parkinson's compared to the controls 5 years after sleep apnea was diagnosed, compared to those with severe, where the curves diverged at 1 year after diagnosis. So even though the odds ratios were the same, there did seem to be some sort of dose effect in terms of time it took to develop it, again suggesting this may be a true result, a true biologic result. Then they looked at CPAP use, and remember, only 9% were using CPAP. And they looked to see if using CPAP diminished the risk. And indeed, it really did. As if you look at the subgroup of people who were placed on CPAP and started using it within 2 years of the diagnosis of sleep apnea, if it was only later, there wasn't a decreased risk, but within 2 years of diagnosis of sleep apnea, the rate of Parkinson's disease did fall. And this time they looked at multiple covariants. They looked at patients with diabetes, with hypertension, with vascular disease, depression, anxiety, multiple things, and found that not a single one of those factors made a difference. If you eliminated those factors compared to the controls, still using CPAP had a decreased rate compared to those who didn't use CPAP. They then said, well, and this is a very important thing in these studies, is the use of CPAP simply a surrogate marker for better general health care? So maybe those 9% were looking after multiple other things. So they looked at healthcare visits, and indeed, those using CPAP visited the VA many more times than those who were not using CPAP. But then they adjusted for that and found again CPAP still seemed to reduce the risk of Parkinson's disease. So very interesting results. I should mention at this point that there are 3 previous studies also using large databases, which suggested the same, that there is a relationship prospectively between sleep apnea and the development of Parkinson's. Smaller numbers and much less well done, much better ascertainment in this study and to check that they really did have the right patients. But there are 3 prior studies suggesting the same thing. And it's always good to have confirmation when you're doing these sort of studies.
Very impressive and absolutely right. So, it seems like almost every journal one reads these days has an article that's based on large population databases. Could you maybe speak a little bit, at least using this article as an example? What do you think, Mike, are the strengths and weaknesses of this research approach?
Well, firstly, the strengths in this particular article are the huge numbers involved and also the care the authors took to be sure their diagnoses were correct and to try correct for as many factors as they could. Obviously, there are things they could not take into account, the low percentage of patients using CPAP, etc. So let's look at the cautions, the possible errors that can go into these studies, even the best ones done. And the first one I always look at when I read these studies, are the diagnoses correct? For instance, one looks at, say, a different study, which is looking at factors which might cause dementia. And you look at it, and it's an insurance database study, not like this one, which is a clinical database study. And they looked at the codes of dementia, but they never checked to see whether these patients really had dementia. And you worry that somebody wants to order an MRI scan or something, so they put in dementia as a code for insurance purposes. It doesn't mean the patient has ever been confirmed as having dementia. So you've got to be very careful with correctness of diagnoses. And as I said, the study was very careful with doing it. The second thing that we should look at is ascertainment bias. Did they pick up all the patients correctly who have these diagnoses, both the factor they're looking at, in this case sleep apnea, and the fine outcome, which is Parkinson's disease? And it's very difficult. They probably missed patients with sleep apnea who never went to the VA complaining of snoring. That's certainly possible. They might have missed people with Parkinson's disease. Some of them might have sought care outside the VA system. You just don't know. But you've just got to think about these things. I think the huge numbers are such that that's probably not a major factor here. Then the other very important factor I always look at, do they correct for comorbidities? Because so often it's not necessarily the factor they're looking at, but something that's comorbid with it. And in this case, they didn't seem to correct the primary analysis for vascular risk factors. And, we do sometimes think maybe that vascular Parkinsonism may occur, but it's certainly not as common as neurodegenerative Parkinson's. So the fact they didn't correct for hypertension, as far as I could see, is probably not a major thing. But you've got to always think about were comorbid factors corrected for in the control group that is selected. The next important thing is this really prospective? Is it really an incidence study in all of these? Because, of course, it's not prospective. All of these database studies are retrospective, trying to predict incidence from retrospective data. Now, these authors were very conscious of this, so they did the sensitivity analysis of waiting a year to see before they started saying Parkinson's wasn't present before. But even so, they may have missed cases in which symptoms were present prior to the onset of obstructive sleep apnea, but they tried their best. But you've got to be very careful with this. The other thing always think about, which is related to this, is reverse causation. Are we sure it's not the other way around? That, say, in this case, Parkinson's disease really was present before and caused obstructive sleep apnea. Well, there's not a lot of strong data that Parkinson's predisposes to sleep apnea, and it looks like they would try to be careful to see that there wasn't reverse causation. But one has to think about that. Also, could the outcome of interest really be the initial manifestation of the disease? For instance, there are multiple studies looking at short sleep duration causing or related to dementia. And all of them suggest that, yes, short sleep duration predisposes to dementia. But you just have to ask the question, could short sleep duration be an initial manifestation of dementia? Now, I don't think that is in these studies because some of them go decades before any cognitive impairment. And we really don't think patients with dementia have insomnia 30 years before is part of the beginning of amyloid deposition. But you've always got to think about that as well. Then the other thing we talked about already a little bit about is healthcare utilization bias and healthy user bias. Are the patients who develop, this is important in therapeutic studies, are the patients who are put on therapy, in this case CPAP, just better healthcare users? Do they better control their hypertension and their diabetes and their depression and everything else? And could this be a factor rather than what we're looking at, such as sleep apnea? Again, if we're talking about idiopathic Lewy body Parkinson's, neurodegenerative, there's not a lot of evidence that these factors are going to increase the risk of Parkinson's, but they might, and one just has to think about this and correct for it. These authors very carefully corrected for patients who used more healthcare, had more visits, and they still found CPAP seemed to reduce the risk of Parkinson's development. So I thought this was just a very useful article, not just in its own right, but just to alert people to the sort of errors that can occur in these database studies, because we're going to see more and more of them. And I think it's important also to mention that these studies, very interesting outcomes, they are not as significant as carefully designed prospective studies. The problem is carefully designed prospective studies. You need large numbers of subjects. You need long times. They followed these patients up for about 5 years in this retrospective study that we've just discussed. You need long durations to get significant outcomes, and they're very expensive. So these retrospective database studies are surrogate studies, but they are probably the best we're going to get in many cases.
So, if we assume that the results of this study are indeed valid, then, Mike, what could be the possible mechanisms here, and how should this impact, or should it impact our clinical practice?
Well, very interesting. The authors suggest that the intermittent hypoxemia and perhaps hypercapnia of sleep apnea might result in mitochondrial dysfunction. Maybe increased free radicals might be a cause, and there's an increasing interest in that. Also, interest in the role of inflammation in neurodegeneration. So there are some plausible biologic mechanisms, because sometimes you read these studies and you say, I don't know. I can't think of any biologic reason why there should be this association. That always worries one as well. But in this case, they've got plausible mechanisms. How should it influence studies? Well, they analyzed that you would, in their study, I mean, it's a theoretical analysis, but nice to do, that you would have to treat 439 patients for sleep apnea to prevent one case of Parkinson's disease. I mean, these are theoretical analyses. So is that really practical? Is this really going to affect our practice? I think the bottom line for all this is just another reason for you to think about treating patients with obstructive sleep apnea. Certainly, this isn't as important as correcting sleepiness, worrying about cardiac, vascular, and cerebrovascular disease, but it's just something else to throw into the mix, and very interesting results.
Well, thank you so much for sharing your expertise with us today, Mike. Do you have any final messages to leave with our listeners?
Well, I think more and more we're going to be seeing these studies. And as I mentioned, most of them come out of insurance databases rather than clinical databases. Be sure you think of all the possible errors before coming to believing the conclusions, especially are the diagnoses correct? Have comorbidities been carefully excluded? Has to look at it very carefully and realize that these do not have quite the same validity as a prospective study would. So it's good to be sure there's a plausible biologic mechanism, and ideally that there's more than one study which shows consistent results. Many times there are 2 or 3 studies using different databases and they have conflicting results, and then one is really worried about the conclusions. So look carefully at these studies. Don't just read the conclusions and be sure they're correct. But when they're well done, like this study is, they can contribute to the literature and help our understanding of these disorders.
Thank you, Mike. And thank you to our listeners for joining us today.
We hope you enjoyed this podcast. If so, please tune in again through wherever you receive your podcasts as we discuss further topics in sleep medicine and sleep health. Thank you.